Hey everyone, we've got another heart today. This is 1074 in our collection. The heart would have sat in the chest roughly like this. Superior head would be here, inferior legs would have been here, anterior surface coming towards the screen, posterior surface towards the turntable, left would have been over here, right over here. We'll do what we always do, which is try to find the right atrial appendage. This looks to be externally the right atrial appendage. It's triangular in shape, it's broad-based, so let's start there. We open up this atrium and find that there are pectinate muscles that spill outside the confines of the appendage, consistent with a morphologic right atrium. And right away, once we expose this atrium, we do find that there are intraatrial communications or atrial septal defects. So let us take a look at the oval fossa first. And here is the oval fossa. These are the margins that I'm outlining right now with the probe. You can right away appreciate that there are fenestrations, small little fenestrations in the posterior-inferior part of the oval fossa. And then there is a larger defect here, more superior. But then there is also another defect here. And when we put the probe through this, it does in fact exit into the left atrium. So it is an atrial septal defect or an intraatrial communication, but it lives outside the confines of the oval window. So the posterior inferior margin kind of being here. And this in fact is a vestibular atrial septal defect. This is a more recently described kind of atrial septal defect. It is not the same as a primary type atrial septal defect. One, because it's developmentally different, and we have demonstrated with episcopic microscopy that the primary type atrial septal defect is in fact developmentally different from the vestibular ASD, and that the primary type atrial septal defect usually coexists with a common atrioventricular junction or an atrioventricular septal defect, which is not present here. So a vestibular atrial septal defect that we're seeing from the right side right now, coexisting with intraatrial communications in the oval window. So these are the confines of the oval window. Then you see that there is a bar of tissue right here that separates this defect, which in fact is a vestibular ASD. Now, also in the right atrium is the mouth of the coronary sinus. And as always, we'll outline the triangle of Koch, which is guarded by the coronary sinus, the tendon of Todaro, and then the tricuspid valve. And at the apex of this triangle, so somewhere roughly here, is where the atrioventricular node or the AV node would live. So an important electrical structure which can be identified by other structures in the heart. When we turn our attention to the right atrioventricular junction, we do find that there is a 3-leaflet atrioventricular valve. This valve does in fact have connections to the ventricular septum, consistent with the morphologic tricuspid valve. Since this is a morphologic tricuspid valve, we would assume that this ventricle that it is connected to would be a morphologic right ventricle. This ventricle does have coarse trabeculations, and it does have a septomarginal trabeculation, all consistent with the morphologic right ventricle. Of note, you can see that the myocardial walls of this right ventricle are thick, and this was a patient who did in fact have a cardiomyopathy. Now when we turn our attention to the right ventricular outflow tract, once again here is the septomarginal trabeculation with its cranial and caudal limbs. And we find a semilunar valve that has 3 leaflets. So 1, 2, 3, and has 3 sinuses. 1, 2, 3. As we look into these sinuses, we don't see any coronary arteries arising from it. So consistent with a morphologic pulmonary valve. And once again, as always, to note that the semilunar valves don't truly have an annulus. The true annulus is not oval-shaped like or circular as we assume. but in fact, the true annulus would be this semilunar hinge point of this valve. As you can see, the valve leaflets actually are hinged in semilunar fashion, and there are triangles of myocardium that actually come and interpose in between the fibrous valvar leaflets. And then we find the pulmonary trunk, and we find the left and the right branch pulmonary arteries. So now we'll go over to the posterior aspect of this heart. And here we find what looks to be a morphologic left atrial appendage, finger-like, and we see that all the pectinate muscles really are confined within the appendage itself, and that the atrium here itself is smooth-walled, consistent with a morphologic left atrium. Now, when we look at the atrial septum here, we can see the oval fossa. Let me try to keep this open with one hand, and here is the oval fossa itself. You can see this large defect here and then the fenestrations here. And now you can really appreciate that the oval fossa has very distinct margins, and that this intra-atrial communication is actually removed from the confines of the oval fossa. I think it was a little harder to appreciate from that right, which it often can be, but now you can really appreciate the distance between the superior margin of the oval fossa here and this vestibular atrial septal defect. And you can see that the vestibular atrial septal defect lives pretty close to this left-sided atrioventricular valve, which looks consistent morphologically with the mitral valve, has two leaflets and no septal connections. And sometimes these vestibular atrial septal defects can actually get pretty close to the mitral valve. So here's the vestibular atrial septal defect from the left side. And let me see if I can't open that up a little bit more. So now really you can tell from the left what the true margins of the oval fossa are, and then how the vestibular ASD sits in relation to that. We've already talked about the left atrioventricular junction, which is guarded by a two-leaflet atrioventricular valve, and this valve does not have connections to the septum, consistent with the morphologic mitral valve. We can see the papillary muscles here, which are somewhat closely spaced. And then since this is a morphologic mitral valve, we would assume that this ventricle that it leads to and is connected to is a morphologic left ventricle, and there are fine crisscross trabeculations consistent with a morphologic left ventricle. So we turn our attention to the left ventricular outflow tract. We see the anterior leaflet of the mitral valve is in continuity with another semilunar valve. This also has three leaflets, 1, 2, 3. It's got three sinuses, 1, 2, 3. And we can see a coronary artery arising from this sinus. And then there should be another coronary artery, which we will find one of the other sinuses. And I apologize if I can't find it. And there it is. There's the other coronary. So coronary 1, and then here is another coronary artery here arising from the sinuses, all consistent with the morphologic aortic valve. Once again, as the aortic valve is a semilunar valve, doesn't have a true circular or oval-shaped annulus. Its annulus truly is this semilunar hinge shape that is formed by how these valve leaflets are arranged and the interposition of myocardial triangles between the leaflets. Unlike the pulmonary valve, the aortic valve isn't supported entirely by muscle because there is a portion of aorto-mitro-fibrous continuity here. And then here is the ascending aorta. So an interesting specimen with a cardiomyopathy as well as a oval fossa intraatrial communication and a vestibular intraatrial communication.